Clinical approach to assess a cardiac arrhythmia on the basis of symptomatology arising from bradyarrhythmia as well as tachyarrhythmia, such as fatigability, exercise intolerance, dyspnea, palpitation, dizziness, syncopal attacks, or vertigo. These are the usual classifications of usual symptoms of arrhythmias, both brady and tachy একসঙ্গে দুটো পার্টেরই symptomatology কথা বলা হচ্ছে. How would you approach for a patient with suspected arrhythmia at the bedside without the help of ECG machine? Several parameters are much more important for clinical assessment. Then we should go for ECG when it is available. Number 1, pulse with special importance to pulse rate and regularity. Then BP, again with special emphasis on pulse pressure. Then jugular venous pulsation, especially status of the A waves. Then carotid arterial pulsation and the impact of carotid sinus massage on the arrhythmia. And lastly, the intensity of S1 and one point to be remembered, the status of S2 in certain special situation. Now, what would we get from pulse? Rate. Rate is a parameter for differentiation between bradyarrhythmia and tachyarrhythmia. Regularity, সেখানে আমরা দুটো ভাগে ভাগ করে নিতে পারি. একটা হচ্ছে ইরেগুলারলি ইরেগুলার, একটা হচ্ছে রেগুলারলি ইরেগুলার. ইরেগুলারলি ইরেগুলার বলতে আমরা খুব সহজেই বলতে পারি যে ধরে নিই অ্যাট্রিয়াল ফিব্রিলেশন. রেগুলারলি ইরেগুলার আমরা কোনো কোনো ক্ষেত্রে দেখতে পাই অ্যাট্রিয়াল ফ্লাটার বা পার্টিকুলারলি একটা স্পেশাল ইন্টারভেল বা স্পেশাল সিচুয়েশনে যদি রেগুলার বেসিসে premature contraction, both atrial premature contraction as well as ventricular premature contraction থাকে, সেক্ষেত্রে আমরা regularly irregular rhythm পেতে পারি. So rate is a determinant for differentiation of bradyarrhythmia and tachyarrhythmia. Regularity is a determinant of certain arrhythmias like atrial fibrillation or atrial flutter or premature contraction, both supraventricular premature contraction as well as ventricular premature contraction. Then BP. Certain arrhythmias like complete heart block, there is an elevation in the level of systolic BP while diastolic BP remains normal. So that may result in wide pulse pressure. So assessment of BP with elevation of systolic BP and widening of the pulse pressure is an indication for complete heart block. Then impact of carotid sinus massage. Certain arrhythmias, mainly that is vagal tone dependent arrhythmia, respond to carotid sinus massage, as for example paroxysmal supraventricular tachyarrhythmia অর্থাৎ AV nodal re-entry tachycardia, especially বা otherwise designated as paroxysmal supraventricular tachycardia terminates with the application of carotid sinus massage. But caution or caveat অর্থাৎ ক্যারোটিড সাইনাস ম্যাসাজের আগে আমাকে লক্ষ্য রাখতে হবে যে প্রেজেন্স অফ ক্যারোটিড থ্রিল or carotid bruit or carotid murmur. Presence of the carotid thrill or bruit or carotid murmur is a contraindication for initiation of carotid sinus massage because that may induce syncopal attack or even cardiac arrest and death. The intensity of S1. PR interval is long, the H1 intensity is diminished, PR interval is short, H1 intensity is increased. And number two, the variability of S1. Beat to beat variation or variation in the intensity of S1 constitute a diagnosis of either atrial fibrillation or complete heart block. Short PR interval produces accentuated and loud S1. Long PR interval diminishes the intensity. Complete heart block produces a beat-to-beat variation in the intensity of S1 as well as atrial fibrillation produces variation in the intensity of S1. Then S2, presence of RBB, right bundle branch block, produces wide split of the second heart sound best heard at the pulmonic area, but RBB plus presence of the right heart failure produces wide and fixed split. RBB only produces wide split of the second heart sound. And the status of AOF in the jugular venous pulsation. Canon AOFs is present in certain arrhythmias. Canon AOFs may be regular, may be intermittent or irregular. Regular is seen in case of supraventricular tachyarrhythmia, especially paroxysmal supraventricular tachycardia, that is AVNRT. Intermittent canon AOFs is present in a setting of complete heart block and AV dissociation. Now, summarizing the parameters, number one, pulse rate and rhythm or irregularity. Irregularity may be regularly irregular or regularly irregular. Second, BP with elevation of the systolic BP and widening of the pulse pressure. Third, impact of carotid sinus massage. Fourth, status of AOF in the jugular venous pulsation. Fifth, status of S1 at mitral area. And lastly, the split of S2 in the pulmonic area. এই প্যারামিটারগুলো দেখে আমরা মোটামুটি একটা আইডিয়া পেতে পারি যে পেশেন্টে কোন ধরনের এরিথমিয়া আছে। এবার এক্সাম্পলে আসছে। ফর এক্সাম্পল, presence of two AOFs in the jugular venous pulsation and one pulse at the radial is suggestive of 2:1 AV block. Presence of low heart rate, wide pulse pressure with elevation of the systolic BP plus irregular canon AOFs in the jugular venous pulsation with variable intensity in H1 constitute the diagnosis of 2:1 AV block. Tachyarrhythmia or tachycardia with irregular rate, hypotension and presence of the regular canon AOFs and termination on carotid sinus massage constitute the diagnosis of supraventricular or paroxysmal supraventricular tachyarrhythmia. Prolongation of the peer interval, that is first degree heart block, is diagnosed by the diminished intensity of S1. এইগুলো রাফলি বলার চেষ্টা করছি, কিন্তু each and every arrhythmia can be assessed at the bedside with these 5 parameters. No ECG is necessary. ECG is a supplementary, or ECG is a supplementary process for confirmation of diagnosis, and ECG should be analyzed on the basis of the QRS complex duration, P wave and QRS relationship, visibility or non-visibility of the P waves, and definitely the rate of the cardiac rhythm rate of the ventricles. এর উপর বেশ করে আমরা ইসিজি অ্যানালাইসিস করব, কিন্তু ইসিজি পড়ানোর সময় যখন ইন্ডিভিজুয়ালি বলবো তখন সেগুলোকে ব্যাখ্যা করব। সো হিস্ট্রি, symptomatology, second special emphasis on the clinical parameters for the arrhythmias, and third ECG for confirmation of the diagnosis. Now we're going into the special forms of arrhythmias. Today's class is tachyarrhythmia. That means heart rate more than 100 beats per minute. Now, classification of tachyarrhythmia. Broadly, tachyarrhythmia can be 2 types: supraventricular tachyarrhythmia and ventricular tachyarrhythmia. Supraventricular tachyarrhythmia means the origin of arrhythmia is at SA node, atrium, or AV junction, or AV node. So above the level of the AV node and AV junction, any tachyarrhythmia is designated as supraventricular tachyarrhythmia. And arrhythmia below that level, that means in the Purkinje system or in the ventricular myocardium, constitute the basis for ventricular tachyarrhythmia. Now, supraventricular tachyarrhythmia. First, sinus tachycardia. Sinus tachycardia means a heart rate is usually in the range of 100 to 220 minus age. অর্থাৎ এটা ভেরিয়েবল, 100-র বেশি কিন্তু 220 মাইনাস এজ তার কম। দিস ইজ দ্য রেট। নাম্বার 2, rhythm is regular. Number 3, morphology. Morphology of PO is normal to sinus morphology. Morphology of QRS is normal to sinus QRS morphology, and peer interval is usually short compared to the normal sinus rhythm. Free morphology normal, QRS morphology normal, rate is regular, and rate in the range of 100 to 220 minus age. Onset is gradual, offset is gradual, no impact on carotid sinus massage on this particular arrhythmias. And what is onset is gradual, that means there is a warm up period or warming period for gradual acceleration of the pulse rate, and the termination is also gradual, that is gradual deceleration or termination of the arrhythmia. Show tachycardia at a rate of 100 to 220 minus age, regular with normal P morphology, QRS morphology, and sudden onset, sudden offset, and without any impact of carotid sinus massage constitute the diagnosis of sinus tachycardia that may be physiological or pathological. Physiological means in response to exertion, both physical, mental, or emotional, and pathological, that means in response to infection, in response to thyrotoxicosis, in response to cardiovascular disease in the form of congestive heart failure or certain other conditions, as well as due to drugs, especially the sympathomimetic amines or illicit drugs like amphetamine. Management: sinus tachycardia, usual management is identification of the etiologic basis, whether it is physiological or pathological. Correct the original pathology, then sinus tachycardia would resolve automatically. Otherwise, on occasion, beta blocker, calcium channel blocker may be required to control the tachyarrhythmia when it is troublesome, and on occasion, when it is incessant and disabling, then catheter ablation is the ultimate choice. Again, I repeat, sinus tachycardia. First, identification of etiologic basis, correct it. Controlled, that's all. No correction. A trial of beta blocker or calcium channel antagonist. No response, stop. No response, then go for ivabradine. No response, then catheter ablation. Inappropriate sinus tachycardia. Inappropriate sinus tachycardia means sudden onset sinus tachycardia or onset of tachycardia or degree of tachycardia is out of proportion to the degree of physiological stress. This is the inappropriate sinus tachycardia or IST. Repeat: sudden onset, spontaneous tachycardia, or magnitude of tachycardia is out of proportion to the degree of physiological stress, cause autonomic dysregulation, or some neurologic disturbance in a setting of diabetes mellitus, either peripheral neuropathy or spinal cord injury. Management: IST management is virtually more or less similar to management of sinus tachycardia. A trial of beta blocker or a trial of clonidine is attempted. If failed, then antiarrhythmic therapy. If failed, then catheter ablation. সাইনাস ট্যাকিকার্ডিয়া বলতে গিয়ে ট্যাকিকার্ডিয়ার কথা বলতে গিয়ে সাইনাস ট্যাকিকার্ডিয়ার কথা বলেছি, ইনঅ্যাপ্রোপ্রিয়েট সাইনাস ট্যাকিকার্ডিয়ার কথা বলেছি। আর একটা কথা বলে নেওয়া দরকার, সেটা হচ্ছে পটস, দ্যাট মিনস পশ্চুরাল or paroxysmal orthostatic tachycardia syndrome. That means development of tachycardia, sudden development of tachycardia on assuming standing position from supine recumbency produces tachycardia that is disabling and that may also be life-threatening, producing syncopal attacks. This is the postural paroxysmal orthostatic tachycardia syndrome. Cause: this is the inability or abnormal response of the peripheral vascular resistance to act properly in response to the orthostatic stress That means change of posture from supine to standing. The management of faults, number one, recumbency related exercise, particularly supine recumbency related exercise. Number two, elastic stockings for promotion of the venous return from the limbs. Then certain drugs like midodrine or fludrocortisone show compressive stockings of the lower limbs. Number two, increased salt intake. Number three, midodrine. Number four, that ডাক্তার নামটা বের করতে পারছি না তো, fludrocortisone, salt restriction, compressive stockings, fludrocortisone, and lastly midodrine. Then paroxysmal supraventricular tachycardia, that is the result of re-entry phenomenon. Paroxysmal supraventricular tachycardia যে সাব ক্যাটাগরি আছে, নাম্বার ওয়ান AVNRT, নাম্বার টু AVRT, নাম্বার থ্রি pre-excited arrhythmias, and নাম্বার ফোর কি বলবো tachyarrhythmia using accessory pathways. Using accessory pathways is more or less similar to AVRT. Now, what is AVNRT? Supraventricular tachyarrhythmia utilizing the functional and structural inhomogeneity circuit in the AV node produces tachyarrhythmia through the phenomenon of re-entry. This is the AVNRT. ECG features is tachyarrhythmia without visible P wave because simultaneous activation of the atrium and ventricular produces narrow complex tachycardia with a rate of 150 to 200 beats per minute with certain exception, AV nodal re-entry tachycardia. Clinical diagnosis আগেই বলা হয়েছে, tachyarrhythmia, hypotension, impact of the carotid sinus message, and the regular A waves, canon A waves in the jugular venous pulsation. Reciprocating AV re-entry tachycardia, AVART, that is the tachyarrhythmia utilizing the accessory pathways. Then the pre-excited tachyarrhythmias. Pre-excited tachyarrhythmias কিন্তু আগের দিন ক্লাসে পড়ানো হয়েছে, particularly James bypass tract, bundle of Kent, and myofibers. আগের ক্লাসে clearly notes আছে. Management. Supraventricular tachyarrhythmia is managed by number one, vagal reflex or vagal maneuver like carotid sinus message. No response. Then beta blocker or calcium channel blocker. No response. Then try for antiarrhythmic therapy. No response. Catheter ablation. On the other hand, hemodynamic instability, urgent cardioversion, repeat or incessant or recurrent, then catheter ablation. This is the management of supraventricular tachyarrhythmias. Now, atrial tachycardia. Atrial tachycardia means a tachycardia arising from the atrium other than the SA node. When SA node is diseased or SA node is defunct, a focus in the atrium, anywhere in the atrium, produces a small re-entry circuit producing focal atrial tachycardia. ECG manifestations is অনেকটা সাইনাস ট্যাকিকার্ডিয়ার মতো, কিন্তু পি মরফোলজি ইজ ডিফারেন্ট ফ্রম সাইনাস পি মরফোলজি. What is sinus P morphology? Sinus P wave duration is less than 0.11 second. Amplitude is 2 to 3 millimeter and configuration is gently rounded. So normal P morphology is with a duration of 0.11 second, amplitude 2 to 3 millimeter and as gently rounded in shape. Best visible in lead 2, 3 AVF. It is positive in lead 1, lead 2 AVF, negative in AVR and biphasic in V1 with a terminal negativity. And it may be biphasic or positive or negative in lead 3. It is variable. So this is the normal P morphology. So focal atrial tachycardia is a regular narrow complex tachycardia with the abnormal P morphology. Management is like that of IST, that is inappropriate tachycardia. Multifocal atrial tachycardia. At least consecutive 3 distinct P wave morphology constitute the diagnosis of multifocal atrial tachycardia. At least 3 distinct P wave morphology constitute the diagnosis of multifocal atrial tachycardia. আগেরটা বলেছিলাম focal atrial tachycardia. Multifocal atrial tachycardia summary হচ্ছে narrow complex supraventricular tachyarrhythmia with altered or distorted P waves consecutive 3 at least constitute the diagnosis of multifocal atrial tachycardia. Most common cause is pulmonary pathology, especially chronic obstructive pulmonary disease with severe degree of hypoxemia or other intensive lung disease. The classical management of choice is correction of hypoxemia, that is oxygen supplementation. Atrial flutter. Atrial flutter is a macro re-entrant phenomenon. Atrial fibrillation is the micro re-entry phenomenon. Atrial fibrillation has got multiple foci of re-entry phenomenon. আগে পড়ানো হয়েছে atrial fibrillation, সেখানে পরিষ্কার করে মেনশন করা হয়েছিল multiple small re-entry circuit produces atrial fibrillation, যেখানে atrial rate হচ্ছে 350 to 600 beats per minute এবং অনেক সময় দেখা যায় বা অ্যাসেস করা যায় না rate from the surface ECG. Now atrial flutter is a macro re-entrant circuit. Re-entrant circuited main basic ব্যাপার হচ্ছে একটি anatomic substrate দরকার. This is the cavotricuspid substrate. The cabo-tricuspid substrate. What is cabo-tricuspid substrate or cabo-tricuspid reentrant phenomenon? This is constituted by number one, orifice of the inferior vena cava, or orifice or entry point of the inferior vena cava to the right atrium. Sorry. Crista terminalis, that is the superior vena cava and inferior vena cava, তার মধ্যে একটা muscular ridge. The eustachian ridge, coronary sinus এবং inferior vena cava, this is the eustachian ridge. And lastly, the tricuspid annulus. So, cavo-tricuspid annulus or travo-tricuspid complex has got number one, inferior vena caval orifice, number two, crista terminalis, number three, eustachian ridge, number four, tricuspid valve annulus. This is the substrate, and a reentrant phenomenon occurs, producing typical or classical atrial flutter. And what is atypical or type 2 atrial flutter? This is non-cavo-tricuspid dependent atrial flutter is atypical atrial flutter or type 2 atrial flutter. So, cavo-tricuspid isthmus non-dependent atrial flutter is type 2 atrial flutter. Now, classical or typical atrial flutter. তার দুটো সাব ক্যাটাগরি আছে. Number one subcategory is the counterclockwise re-entry phenomenon, and the clockwise re-entry phenomenon. Counterclockwise re-entry phenomenon is the most common, and clockwise is a lesser common. Counterclockwise re-entry produces the negative P waves or negative P deflection in the surface ECG, whereas clockwise re-entry phenomenon produces positive P wave configuration in the surface ECG. Surface ECG produces a sawtooth pattern of atrial activity at a rate of 250 to 300 beats per minute with a ventricular rate of 130 to 150 because atrial flutter is almost always associated with a degree of AV block that may be 2:1 or 3:1. Classical management is DC cardioversion. Low energy output DC cardioversion, usually 10 to 20 joules cardioversion, is enough to terminate an atrial flutter. Otherwise, rate control strategy may be initiated like dofetilide, like antiarrhythmic therapy, or classical beta blocker or calcium channel antagonist. Now, ventricular tachyarrhythmia. Ventricular tachyarrhythmia etiological ব্যাপার হচ্ছে ফার্স্ট অ্যানাটমি. ফোকাল হতে পারে. ফোকাল মিনস মায়োকার্ডিয়াল সেলস বা হিস পার্কিনজি সিস্টেম, আর এমনি কোনো স্কার বা কোনো প্যাথোলজি থেকে. অর্থাৎ যদি মায়োকার্ডিয়ামে কোনো স্কার বাই দ্য প্রসেস অফ ইদার ইনফার্ক্ট অর কার্ডিওপ্যাথোলজিক্যাল ইটিওলজি, সেখান থেকে মায়োকার্ডিয়াল স্কার তৈরি হলে একটা ফোকাল সাইট তৈরি হচ্ছে, যেখানে অটোমেটিসিটি বা ট্রিগার্ড অ্যাক্টিভিটি প্রডিউসেস দ্য ventricular tachycardia. Otherwise, ventricular tachycardia is also produced by re-entry phenomenon. Show ventricular tachycardia mechanism, automaticity, triggered activity, and re-entry phenomenon. ECG features: wide complex tachycardia, tachycardia with a duration of 0.12 seconds, that is regular, with intermittent canon A waves in the jugular venous pulsation. Now, ventricular fibrillation. This is the absolute form of ventricular tachyarrhythmia, a sine wave configuration or bizarre QRS complex with absence of P wave, and there may be twisting of the points, that is the torsor de pointes. This is the ventricular fibrillation. Management of choice: DC cardioversion, rapid atrial flushing, or ablation therapy. That's all. অনেক কিছু বলা হলো, এর মধ্যে AV dissociation. What are the causes of AV dissociation? AV dissociation is done by sinus default. Number 2, done by usurpation. It is a junctional tachycardia or ventricular tachycardia. And lastly, sinus default, AV dissociation by usurpation, like tachyarrhythmia, especially junctional tachyarrhythmia or ventricular tachyarrhythmia. Lastly, complete heart block. And one point আমি মিস করে গেছি, সেটা ক্লিয়ার করে দিচ্ছি। সেটা হচ্ছে আমি জাংশনাল ট্যাকিকার্ডিয়া সম্পর্কে কোনো কথা বলিনি। জাংশনাল ট্যাকিকার্ডিয়া যেখানে সাইনাস নোডাল ডিসফাংশন থাকে, সেখানে জাংশনাল ট্যাকিকার্ডিয়া ইজ প্রেজেন্ট, and usually junctional tachycardia is associated with organic heart disease, especially organic heart disease involving the AS node or total atrium. Junctional tachycardia is a narrow complex regular tachycardia with retrograde P waves. Retrograde P waves, it may or may not produce AV dissociation. This is the junctional tachycardia. And what is accelerated junctional rhythm? That means junctional rhythm but not within the range of tachycardia. That means slow junctional rhythm with absence of the P wave, but rate is less than 100. This is the junctional escape rhythm or idioventricular rhythm.